Okay. Hello, web shadowers. Thank you all for attending our session this afternoon. Today, we have the pleasure of hosting Dr. Nagy, who will be teaching us about plastic surgery. As always, please remember that the Google form will be posted in the chat box and in the description of this video at the end. With that being said, Dr. Nagy, you may start whenever you're ready.
Okay, great. Thank you, Isis. My name is Dr. Celeste Nagy. I'm a facial plastic surgeon. So I am going to talk to you today about analysis of the aging face. This is a small part of what I do, but I want to first kind of talk about, I can tell you a little bit about my background. I understand that a lot of you are pre-meds or maybe even in high school and looking to get into medicine. So I can talk a little bit about my background, how I got here, and then sort of explain what facial plastics is and the different topics I cover, and then we'll sort of get into the meat of the conversation. So first, so I went to University of South Carolina for college. Then I went to Baylor College of Medicine. I took a gap year and worked in AmeriCorps in Austin, Texas for a year. Then I went to medical school at Baylor College of Medicine in Houston. I then did my otolaryngology, which is ENT, and had a neck surgery residency at Emory University in Atlanta, which is a 5-year program. And then instead of doing practicing general ENT, I am currently doing a 1-year fellowship in Indianapolis with Dr. Stephen Perkins in facial plastics. And then I will be joining a private practice in Atlanta, Georgia, when this year is over in July. So what facial plastics is, so I'm technically a facial plastic and reconstructive surgeon. So it is a variety of things. There's both the cosmetic and reconstructive aspect. From a cosmetic standpoint, it varies from skin resurfacing, like lasers and things like that. Everyday things that I do in the clinic are things like Botox and dermal fillers for cosmetic enhancement. Additionally, I do rhinoplasties or nose jobs, both for functional, which means difficulty breathing, and for cosmetic purposes. We also do aging face surgeries, which are things like blepharoplasties or eyelid lifts, face lifts, brow lifts, which we'll kind of get into that a little bit later in this talk. My favorite procedure is rhinoplasty, but it is challenging. And then on the flip side, the reconstructive aspect are things like facial trauma. So if you get in a car accident or fall, break your mandible, break your orbit, have a cut on your face, a facial plastic surgeon would ideally be the person fixing it. And then skin cancer reconstructions. So I actually just got out of the OR. A woman had a skin cancer here on her nose that got resected and the entire tip of her nose was gone. And I just did a reconstruction with actually bringing a skin flap down from the forehead, and we'll be reconstructing that. So it's a very intricate and complicated procedure or specialty and very dynamic, a lot of different options. But I'm going to just be sort of focusing on the aging face and the cosmetic portion today. So to start off, the thought about the aging face and analyzing aging faces has been around since humans have existed. For example, in this Leonardo da Vinci painting, who is a master of recognizing the details of the face, he depicts the differences in the profile between an old man and a young man and just the changes that develop in your face over time. So what causes aging? What causes these changes that we so inherently see? It can be a combination of heredity, hormonal imbalances, weight fluctuations, like the very gaunt appearance versus a heavier person may have a smoother contour appearance, damage to skin, causing more wrinkling and all these spots that you can see on this gentleman, stress, things like alcohol, smoking, microvascular disorders can compromise your skin and make you appear older. Additionally, there's collagen disorders that don't allow tight elasticity of the skin, and it causes it all to hang. An example is cutis laxa. I really like this picture because this is a gentleman who was a truck driver and who didn't use sunscreen and got a lot of sun exposure. And the patient's left side was the one facing the window because he'd go on these long truck drives and there's really significant rhytids or wrinkling. excessively saggy skin, and you can just tell it looks kind of older, leathery compared to the right side, which did not get the sun exposure through the window, and it's just a lot smoother and better skin overall. And this is just strictly sun damage. So we can inherently, when we look at these pictures of the same person, but aged, and we can inherently see that one is the one on, I don't know if you can see my pointer, but the one on the right is inherently younger looking than the one on the left. Things like wrinkled furrows between his eyebrows, wrinkles on his forehead, the deep, what we call nasolabial folds right here between the nose and mouth. There's platysma bands showing up through the neck and banding, and just kind of the skin is drooping overall compared to the younger version. So what causes these changes? Well, that is at all the different tissue levels, there's changes over time. So that includes at your skin, your fat of your face, the myofascial layer, which I'll go into a little bit, and the bone layer. All of these combinations create what's called an aging face appearance. So first of all, is the skin. We'll first cover the skin, which you lose elasticity over time, which causes your skin to stretch and doesn't remain tight to your jawline or tight to your face, and can cause these folds like you can see demonstrated in this photo, like the frown lines here, the horizontal it's across your face. The skin begins to sag and causes those deeper furrows along the nasolabial folds and what we call the marionette lines at the mouth. There's also these tissues called cutaneous retaining ligaments that help the skin stay positioned on the face upwards. So the important ones, which we'll demonstrate in a little bit, are the zygomatic, masseteric, mandibular, and cervical. And as these stretch, it leads to loss of support and sagging skin. So therefore, the effects of gravity, the loss of the cutaneous ligament strength, and the loss of elasticity over time cause both anterior and inferior displacement and of the skin. So these are the ligaments I'm talking about. This is, I understand, kind of beyond probably a lot of comprehension, but it becomes important if you're doing facelifting, because essentially you have to release those ligaments in order to reposition the deeper tissues and the skin and give you that lift that you require in surgery. So the zygomatic retaining ligament is here along the zygoma. The masseter is here in front of the masseter muscle. The mandibular is here along the mandible anteriorly, and then the cervical are back here where your platysma and SCM or sternocleidoid mastoid muscles interdigitate. And again, I'll show you some more photos. So the next part that causes aging face is fat. There's twofold reasons why that causes it. There's fat atrophy or loss of fat, making you look hollow, making you look more shrunken. And then there's fat descent, which those fat pads start to descend over time, and they can cause those jowls. They can cause your midface to really look low. It can also cause the under eye bags as the fat from your orbit herniates out under your lid. And those are all because your fat is both losing its fullness and it is herniating into different places, causing bulges on the face. This is actually an example of a patient. I actually repaired her skin cancer defect. You can look at her left nostril compared to right using a forehead flap like I just did. But more importantly, she also had a gastric bypass several years ago and lost a ton of weight. But by losing that weight, it caused her to have a more hollow and skeletal appearance. You can see her temple, which is here, is really shrunken in. And she also has really kind of sunken in looking eyes. And also in her midface, instead of having a nice smooth contour of her cheek, it looks sunken in as well. And that's all due to fat loss over time. And then, of course, those sort of vertical rhytids around her skin, she's lost elasticity, and it's just really showing. Instead of nice, smooth skin, it's got those deeper furrows. So this is what I was talking about, the fat compartment's descent over time. If you look at this kind of animation on the left, you can see the surface level on the top row and then the deeper layer on the bottom row. On the surface, you can see that the skin on the first person, who's probably in their 20s and 30s, is nice and tight, nice and smooth, and all the fat compartments are really retained nicely. Then as you age, this middle one is probably in their late 40s, early 50s, the skin begins to loosen and that fat starts to descend below the jawline, causing those jowls. And then the last column, this person's probably in their 70s or 80s, and you can see the deep nasolabial fold furrows. You can see how much the fat has descended from the cheek and from the jawline down below the mandible, and it causes this sort of sunken, hanging appearance along the jawline and the midface. And then in a real person, you can see that this person is starting to develop bags under their eyes. They've got fat pockets here. Instead of having the fat part of their cheek high, creating a smooth lid cheek junction, it's now sunken and hanging down. And then they're starting to develop this jowl because the fat pad that was there is now sinking below the mandible. So next comes the myofascial layer. So there's a layer under your skin and under your fat called the superficial musculoaponeurotic system, or we just call it the SMAS. And it is continuous with the platysma of your neck, which is called like the chin strap muscle. When you go like this, you can see those bands forming, and it is what holds all of your facial muscles that make different movements. It holds all of those in place. But over time, like every other tissue of the body, it loses its integrity, it loses its strength, and it becomes stretched. And so that stretching, or kind of disintegration of that layer, causes all of this fat to herniate, causes the skin to sag. So this is the layer that's really targeted when you're doing a facelift, because you need to resuspend that layer into a more youthful sort of both appearance but also position that it has descended over time. So you're actually bringing it both up and back in what's called a superior and posterior vector. So then lastly, we're going to talk about the changes in your bone that lead to an aging face. So as we get older, your bones resorb, they become weaker. It's apparent in patients who have falls, and they more easily break their bones and things. But it can also cause changes in your face. So for example, in this photo, we see the 35-year-old, and they've got kind of a tight orbit. They've got a high malar eminence or zygoma bone or cheekbone, and then their mandible is nice and strong and defined. However, as she ages, you can see that there's more expansion of the orbit, and it drops the cheekbone down. The cheekbone gets smaller, the mandible gets smaller. So all of the soft tissue above it can just sag and kind of descend over time. So due to these bony changes underneath, there's not as much skeletal support of the soft tissues, so they begin to descend over time as well. So here's a good graphic that I like that's a split face of understanding the aging face. A youthful face has nice, smooth contours. There's a short distance between the lower lid and the cheek. The cheek has a high, what's called malar fat pad and malar mound. There's a smooth convex contour, soft nasolabial folds. There's not these deep furrows. It's just a smooth kind of continuous face. Whereas on the flip side, due to all those changes of the tissues that we discussed earlier, you begin to have, deep furrows of the forehead, elongation of the distance between the lower lid margin and the cheek. You get deeper nasolabial folds, both from the loss of skin elasticity and that fat pad descending down. Same thing, you develop jowls here because that fat is descending down below the jawline. So this is a photo of Cindy Crawford, and the way that I like to think of aging face is to break it up into 3 different sections of your face. So this is called the horizontal thirds of facial analysis, and it goes from what's called the trichinum, or basically the widow's peak of your scalp, down to what's called the glabella, or the area between your eyebrows, and then from the glabella to the subnasalis, or right beneath the nose, and the subnasalis to the menton. The menton is the most anterior point in the center of your chin. So those are the 3 main ways to break up the face. And then of course the neck it would be the 4th way. So first we're going to focus on what's called basically the upper 2/3 of the face. So the forehead and what's called the midface. So this is something that's more important for people that are already in residency training. I think it's a little above your what you need to know. But ultimately, there are mathematical equations that determine what the ideal brow position is. And overall, you want the medial or middle part of the brow to line up with the outside of your nose, as you can see in this top picture. Men don't really have much of an arch, and their eyebrow usually sits right on their brow bone, whereas women have an arch above the brow bone, and it just sort of frames the eyes. This comes into importance when people have a lot of extra skin on their eyes, or they feel like they look older or tired, and they just want their eyes to be refreshed. Additionally, in the Caucasian eyelid, which means a non-Asian eyelid, there is a distinct crease between the lid margin and the rest of the eyelid. And essentially, in males, you want that distance to be about 6 to 8 millimeters, and in females, you actually want it to be longer, 8 to 10 millimeters. In some Asian patients that don't have that crease and want to do that, that's a specialty type of surgery called the Asian upper eyelid blepharoplasty. But that's a really complicated topic that's beyond the kind of bounds of this. But essentially, that's the quote unquote ideal measurement that you want if you are creating that creased eyelid. So that comes into importance when you're measuring in order to do surgery. So essentially, let's say this patient comes in and he's complaining of looking tired. He feels like he can't read as well, especially at night. His eyes feel really heavy. So some certain history you want to get on him is, does he have excess skin on his lid? Does he have herniation of fat in the lids, or is he really skeletal? Is he having any sort of vision defects? And then is he having something called ptosis, which I'm going to get into in a little bit. And then also, are his eyebrows too low? And that's what's causing a big part of the problem. The other thing you need to check for is if he is too open like this, then does his lid need to come down? So those are important things to evaluate the patient when they're complaining of their upper eyelids. I'm going to skip over that part. So this is an example of a 27-year-old who had this kind of bump on her eye and was concerned that it was a fat pad, but actually out laterally are something called the lacrimal glands. That's what produces your tears. So they usually are tucked up under the bone, but sometimes if they get overgrowth, they descend like this girl's, causing a bulge. And you can do a little incision and sort of pexy it up, or sort of tuck it back under the bone and sew it in place if needed. So the next thing is something called ptosis. What ptosis is when your eyelids, as you can see in the photo here, your eyelids sort of droop due to a nerve function in a weak muscle. So essentially, the levator muscle, which is an atomic muscle that keeps your eyelids open at a certain point, and you measure this with the distance between the lid margin and the light reflex of the pupil. These are different grading scales. It's again kind of beyond the purposes of for your knowledge, but just something to be aware of. So I'm going to show you some photos. So this actually is a woman who had her, you can see in the first photo, the right eye is much lower than the left eye. So she had the ptosis of her right eye repaired, which you can see in the next photo here. However, it then caused her left eye to sink because of how her nervous system is innervating both. So then she had to go back and have the left one repaired. She also had an upper blepharoplasty where the extra skin of the upper lid was trimmed, so that overall she's got a more refreshed appearance. But as you can see now, her eyelids sit much higher above the pupil than they did in that first photo. So this is a surgical photos of that ptosis repair. Just for your understanding, this is the skin layer. This is the muscle layer of the eyelid called the orbicularis oculi. This is something called a tarsal plate, which is actually a cartilaginous plate of your upper eyelid. And this right here is called the levator aponeurosis. That is what actually lifts and closes the eyelid. So because it's all stretched, this is sewing that levator back to that little tarsal plate of your eyelid in order to keep it open at a normal opening. So here's another patient. She's young, but she's got this kind of droopy eyelid on the left compared to the right. And so we did an open ptosis repair, and now her eyelids, no skin was removed. This is just fixing that little weakened muscle, and it causes her to have even eyelids now. So we're back to this patient. So what I see when I'm analyzing him is I see that the tail of the brows are really low, and that's where the extra skin is. He does have redundant skin, but you can see his brow bone is up here, the prominence, and his physical brows are below that. So he needs a eyebrow lift as well as that excess skin trimmed from his upper lid and lower lid. So that is called a endoscopic forehead lift. So he didn't actually have ptosis or droopy eyelids. It was just the heaviness of the brow and the extra skin of the lids. So this is after doing a brow lift, an upper and lower blepharoplasty, and just kind of gives him a more refreshed appearance. And though his brow is still low, on the outside, you can now see it's more even with the brow bone compared to the before photo. Now, this is a woman who also felt like she was scowling and looking angry all the time. But when I look at her, I don't see a lot of extra lid skin, especially right here in the medial pockets. It actually looks kind of sunken. So she didn't need any skin trimmed. She just needed her brows lifted, because you can see how low her brows are. They're sitting below the bone. There's not a good arch to them. So now she's got a nicer arch. She, has light colored brows, but her eyes look much more open compared to here, and she doesn't look as skeletal. So lower eyelids, this is a pretty challenging topic. I'm not going to go into everything you need to evaluate because it's pretty confusing and it's really hard anatomy, but essentially you're looking at if there are bags, the bags you get under your eyes are usually fat that's herniating out. And then there's a muscle that goes under here called the orbicularis oculi. It's a round muscle, like a sphincter around your whole eye. And making sure that that doesn't have a lot of excessive movement. And then you're also checking to see if they have dry eye, if their eyelids roll out, and several other history points, but so I'm going to go over a couple of the main ones real quick. So when you're looking at a profile view, you can see in the B, the middle one is what a normal one looks like, which is just the lid margin's got a smooth contour from the lower lid to the cheek. In A, he almost looks like his eye is bulging out a little bit. It's actually going backwards instead of straight up and down. And in that case, you don't want to take any fat out here because it would just make it worse. In fact, you actually want to build on the cheek to make it look more symmetric. And then in C, this is what we typically see with aging upper and lower lids. You see that instead of this nice indentation and then smooth contour onto the cheek, you now have it coming out like kind of a belly or something. And it's got that what's called herniation of the fat pads, or that's just fat that's bulging out from underneath. So if you are also other things you need to analyze are this bulge here is actually muscle that's overactive. It's not fat because we don't see the fat down here. So that's just something that has to be addressed when you do surgery. This picture on the left shows a woman with really wrinkly skin, really loose skin. So that's something that either needs to be resected or lasered when you do that procedure. Otherwise, she's going to have this odd looking appearance. These are patients with more severe deficits. This one has these multifolds, which are called malar festoons or pouches. You can also see this thickened orbital lid margin. Same thing with this gentleman over here. Not only is it thickened, it's rolling out, called ectropion, and there's a lot of scleral show. Like, you can look at this guy and there's only like maybe a little sliver of white, whereas this guy's got almost, 10 millimeters of show, and it's just very lax. So that means that when you pull the eyelid like this, it doesn't retract back quickly. This is what I was talking about for the lid evaluation. You always, if you're ever going to do eye surgery, need to check if the lid recoils quickly, because if it doesn't, and if it's loose, if you do surgery, it can cause it to roll out and get constant eye issues. So if it is loose, then you have to know in your head when you're doing surgery to tighten that lower lid, whether it be by suturing it or excising a part of it and suturing it. But that's something that's really important if you're doing ocular plastic surgery. So these are different approaches for the lower blepharoplasty. Again, I'm not going to get into this too much because it's kind of beyond the scope of your uh, what you need to know. These are surgical approaches, but essentially one approach is going in through the eyelid where there's no cut on the outside. It's all done in here. And that can be good for young people that have nice tight skin. You can see that she had bags here before, and now it's nice and flat and smooth. But that doesn't work for everyone. So this patient also had that procedure, but now she's left with this sort of deflated balloon appearance because she's got the wrinkly skin that needed to be addressed. So in this case, she may have needed a cut on the outside in order to remove some of this extra skin, or use a laser that can shrink wrap and soften up some of those wrinkles. So the transcutaneous approach is essentially where you make a small, tiny incision on the outside, and that's a technique that is commonly done when patients have a lot of fat or extra skin. Here's another before and after of a patient that had both on the left, you can see she's got extra skin. It's almost coming down to her lash line. She's starting to get some bags under her eyes, some like fine lines and wrinkles. And then over here, you can see now she's got much more open appearance. She's got that nice distance between the margin of her eyelid and the crease of her eyelid, and her lower eyes look much softer and smoother. Here's another patient. When I look at her, I see that the medial eyebrows are kind of sunken below the brow bone. She's got extra skin almost down to covering her lashes. She's got pretty big bags under her eyes. And overall, she came in because she just looked angry. She didn't want to look angry and tired anymore. She said, people always ask me what's wrong, and I don't feel like anything's wrong. I don't feel angry, so I don't want to look this way. So this was after I did a forehead lift, upper and lower blepharoplasty, and you can see her eyebrows are in a better position, that there's more show to her eyes overall, and she just looks younger and more refreshed. So for the midface, which is kind of the eyes and cheekbones here, over time, this fat pad that keeps you nice high cheekbones descends. The cheekbones that are out here sort of shrink in, and those combination of things cause your skin and fat to just shrink and cause the deeper folds here called the nasolabial folds. So there's a lot of different options that you can do for this. In the clinic, I do filler all the time. You can also do facial fat grafting, where you take fat from the abdomen and put it in the face to really make those nice contours. You can also do something called implants, where it's a type of material like silicone, and we actually make an incision under the lip and get to the bone here and actually screw implants in onto the cheekbone itself. And you can see from this photo that she had kind of a flat appearance, and now she's got this nice curve to her midface, and it just makes her look younger and makes her cheekbones pop out more. There's other procedures you can do to physically lift all that fat and reposition it, but it is a more intense surgery where you make an incision under the eye, and you actually make an incision back here in the temple, and you kind of lift everything with sutures up into place. So now we've talked about the upper and mid face. Now we're going to talk about the lower face. This is what is, you often hear the word facelift, and facelift isn't your whole face. It's just really this lower face and neck that it addresses. The procedures we just went over really focus on the upper face. So again, just to reiterate, what happens is loss of skin elasticity, stretching of those ligaments that we talked about that keep your skin in place, decreased strength of the SMAS, or that muscular layer that's below the skin, and then the cheekbones and the mandible resorb and make your skeleton smaller, and everything just hangs off of it. There's also different types of necks. This isn't super important, but this is a classification system where basically type 1 is kind of a 90-degree youthful neckline. Type 2, you're starting to get the laxity and bands. Type 3 means you've got fat under the chin. A type 4 means you've got pretty heavy banding of the platysma muscle. And then 5 means you have a small chin and you don't have good projection. And then type 6 is when something called your hyoid, which helps make that angle here, is maybe sitting low so that you have what's called an obtuse, or instead of a 90-degree angle, it's more like this and creates that heavier looking neck. So we're going to go over the surgery in a little bit, but basically this is just a difference of what this surgery does. It does help with the jowling. It does help with the aging looking neck. It helps with some of the lines around your mouth here, but it doesn't help pull these lines, because otherwise you would look like you were in a wind tunnel. And it doesn't turn up the corners of your mouth like this, because again, you don't want that pulled stretch look. And it doesn't change any wrinkles or sun damage that you have. That has to be dealt with with other treatments. So this is what we'd call an ideal candidate, which is someone who may not really, may not need a facelift right away, but someone who's still got good skin, has very minimal fat, that's herniated, has minimal jowling, but still is just not pleased with the shape and contour of her neck. This is a patient that's a more challenging case because she's got what's called an obtuse neck. Like I said, instead of a 90-degree angle, it's flat looking like this. She's got a small chin. She's pretty heavy. And so she's got really big jowling, heavy cheeks. So these are all just things that make it more challenging to resuspend. Now, there's different types of facelifts. What I'm showing you here is basically there's a skin layer. If you can see my pointer, this is called the SMAS. This has both fat and muscle in it, and this is what is resuspended. And then below that is called the parotid gland, and this layer is moved upwards and it's secured up here, and it just repositions your face, like I said, in a superior and posterior position. I'm not going to get into all the types of facelifts. I think it's, again, a little bit it's very complicated. But then as far as a lot of people, especially now that people are wearing masks all the time, they see their neck, or if they're doing Zoom conferences like this and seeing themselves all the time, they think their neck looks older. And that's what's driving a lot of people to get plastic surgery at this time. So in this patient, when I'm looking at her neck, you can see these bands of the platysma muscle, but she doesn't have a lot of fat. What's really the problem is the skin laxity and the fact that there's really heavy banding going on. So in that case, we do something called a platysmoplasty, where you make an incision kind of right here in the crease, and then you excise those muscle bands and actually plicate it or sew it together, and it recreates a nice, sling of your neck. So this is just like a little bit of a cartoon of the type of surgery that you would do, and these back cuts allow it to have a little bit more flexibility. But again, that's just sort of understanding what the anatomy is, why it's happening that way, and things you can do about it. Other things that we do are facial fillers. In this case, this guy, was bothered by the appearance of these lines. And instead of having surgery, he ended up just getting fillers into these areas, and it really contours it nicely and makes him look a lot younger. Now, other things we can do are implants. So for example, this woman did have a facelift, but she had this deep, what we call a pre-gel groove, like this deep demarcation. And again, that's because the mandible has shrunk. So we put in an implant, which it looks like this, and it's actually done through an incision beneath the chin, so no one really sees it. And it sits right on the mandible bone and is sewn in place. And then we can close it, and it really fills out her jawline so it looks nice and smooth instead of having this big indentation there. Now, remember this lady, this is her after getting her facelift and a chin implant. So ideally your chin sits at the same, if you draw a vertical line from your lip down to your chin, it would sit on the same sort of tangent. But in this case, she had a very regressed chin. So there's lots of different things we can do. You can put fillers in, you can put a chin implant, which we can use different types of material like Silastic or Merceline mesh. You can do something called a sliding genioplasty, which essentially cuts the bone and brings it forward, but then you have to plate it. So it's a very complicated surgery, but it is done sometimes, especially if you're having dental issues. Then an oral surgeon with the help of a plastic surgeon can bring your mandible forward. So in this case, this woman got a pretty nice result for what she started with, but she has addition to her chin projection, which allows her to have a more 90-degree angle than this sort of obtuse neck that she had. Here are some more before and after photos. You can see the jowling, the deep folds here, the platysma, the submental fat and kind of looseness. And now she's got a nice 90-degree angle. These are softened up. There's no jowls. Same thing here. This is pretty minimal, but she now has a nice 90-degree neck instead of having that sort of loose appearance. Same thing here. This woman looks like she's got just basically goes from chin down to the base of her neck. It looks like she has no definition here whatsoever, but you can see that's all just skin. So once that's gone, she's got a nice, long, tight 90-degree neck. And then she also had a lower blepharoplasty, so you can see the bags under her eyes. Now it's nice and smooth. This can also be done for males. This gentleman obviously had a very heavy neck, and now he's a nice, good angle. I'm just going to briefly talk about lips. Over time, your lips age as well. You can see in this photograph comparing a 30-year-old's lips to a 60-year-old's lips. The 30-year-old's has nice definition and borders. There's the Cupid's bow and the two Cupid's peaks. And then the pink part is called the vermilion, and this is called the cutaneous upper lip. The little border that differentiates the two is called the vermilion border. So over time, though, you can get these what are called vertical rhytids. The lip has rolled in. There's more distance between the nose and the vermilion border, and you just lose volume over time. Additionally, there are ratios that are ideal, and it's 1 to 1.6, where the upper lip is a little bit smaller than the lower lip. But on the profile view, the aesthetic ideal is that the upper lip actually pouts out more than the lower lip. And you can see in these older patients that they've kind of lost that and it's all rolled in. So ways to correct sort of these aging lip and perioral areas are you can do hyaluronic acid fillers. But that can also lead to overvolumization. I know you guys all have probably seen Kylie Jenner or those celebrities that have those ridiculously large lips and they now look like sausages because they don't have the same shape anymore. So in that case, that is just over injected. But so there's other surgeries that you can do to sort of both. You can take skin out from here and lift the lip up. You can roll the lip out and excise skin here. You can also do lasers around the mouth to kind of get rid of those wrinkles. And you can also put fat into the lips in order to create more volume. Another important topic is skincare. Skincare is kind of the biggest thing, especially preventative, to start doing in your 20s and 30s. The main scales we use are the Fitzpatrick, which is your skin tone. It goes from 1 to 6. And as you can see, this is a good demonstration of the different types of people that fall into this category, which is why I like this photo. It also determines how much you burn versus tan. So a type 1 is generally what we think of as like a very, very pale person. Maybe they have red hair. They always burn. They never tan. And they have really pink scars. A type 2 is like what I am. And then type 3 is sort of like maybe Asian descent. Type 4 is more like kind of Middle Eastern. And then type 5 is darker Middle Eastern or Indian, and then some African Americans. And then type 6 is generally African Americans that, don't burn. And these are important when it's coming into play as to skin resurfacing, types of skincare, and scar treatment, especially if you're going to operate on them, understanding what risks they have depending on their skin type. And then the other thing that we're looking at is photo damage or sun damage. So that's a different scale, but the type 1 is just maybe like some light pigment changes like freckling, some sunspots, but no real wrinkles. Type 2 is when there's wrinkles in motion, like when you smile, having crow's feet here, and starting to get some early age spots. Pores are more prominent. Type 3 is kind of 50s and older, where they've got wrinkles at rest where they're just etched into the skin. And then type 4 is what you typically see in like very elderly people. They're If they wear makeup, it's just caked in. And again, these are important things to know when you're choosing a skin treatment. So the two main things that we're treating are rhytids or wrinkles and photo damage, which are pigment issues or sunspots. So neurotoxins are things like Botox, Dysport, Xeomin, things you've probably heard of, that you inject into the muscle, and those things actually paralyze the muscle, which don't allow the muscle to move as much, and therefore eliminating a lot of wrinkles and preventing them. There can also be done resurfacing with peels, lasers, things like that, which actually take off the top layer of skin and replenish it from the ground up. Like if you get a scab or if you scrape your knee or something, but it's in a controlled fashion, of course. And then photo damage or pigment issues and sunspots can be prevented by wearing sunscreen daily, but also may need certain more invasive treatments. So here's some cases. I'm just going to kind of run through them. So this is a 68-year-old female who came in and said, "Oh, I look tired all the time. I feel like I just look at myself in the mirror and I don't see myself anymore. I've got a lot of energy, but I don't see that person looking back at me." So when I'm doing an analysis, the first thing I say is, okay, this is a Fitzpatrick type 1 skin. She's got quite a bit of photo damage, really deep wrinkles, especially around her mouth. So Glogau 4. Her eyebrows are low. I can see them below the brow bone. She's got so much excess skin of her upper lid that it's covering her eyelashes. Her lower lids have herniation of the fat and extra skin. She's got, a flat midface and not a lot of support here. She's also got banding of her neck. She's got jowl formation. So I would recommend doing kind of like a total facial rejuvenation with, a brow lift, upper lower blepharoplasty, facelift, and skin resurfacing. So that's what we did. So this patient had a lot, and it does take a long time to, it takes about 2 weeks to really fully recover and heal, and they're pretty swollen afterwards. But the long-term results, she does look like herself, just much refreshed, younger version, maybe 10 to 15 years younger than the person on the left. So she had a forehead lift through an endoscope, which means I used a camera and instruments instead of a big incision. It's just little camera ports. She had an upper and lower blepharoplasty, a facelift. We put a chin implant in, and she had some fillers to kind of help with some of these deeper lines. And then she had a full face CO2 resurfacing, which took away all of those sunspots and those really, really deep wrinkles. So this is a 38-year-old female who comes in and said, "Whenever I take a picture, I notice that I've got this droopy eyelid. So what can be done about it?" So this is ptosis. This is when her left eyelid is droopier than the right side. She still's got a little bit of extra skin on that upper lid. She's starting to have early signs of bags under her eyes. So this patient had a ptosis repair on the left, bilateral upper blepharoplasty, which means just that little bit of extra skin was removed, and lower blepharoplasty, which means the fat was removed that started to bulge out. This is the last one. Now, this is a gentleman. Again, he's about to retire. He just feels like he looks too old, even though he feels young. He likes to golf, and he just overall wants to look better. Now, it's hard to do a brow lift in this patient because he has such a high hairline and is balding. So actually, in this case, we did a brow lift where we actually made the incisions within these already existing wrinkles on his forehead in order to camouflage the scar in there. Also did he's got extra skin of his eyes and the bags under his eyes, so he needs that removed with a blepharoplasty. You can see the deep V here of his cheek that's really fallen, and so he needs some mid-face, filler and fat grafting. And then he's got the jowls and sort of the heavier neck that can be addressed with a facelift. So this is that gentleman. You can see that his forehead lift scar just sits nicely. It just looks like normal wrinkles, but these wrinkles are gone because we put some Botox in here. He's now got a little bit higher eyebrows. You can see that crease in his eyelids that you can't see over here. The lower eyelids are nice, soft, and flat, and his chin and jawline are nice and smooth. He doesn't have that big, heavy neck anymore. So that's all I've got. Are there any questions for me?
Thank you so much, Dr. Nagy. I sent in all the questions in the chat box.
Okay. Okay, so I'm just going to read these out loud and then I'm going to answer them. Okay, can you talk about the regenerative capabilities of skin cells? That is, does the skin age due to being unable to repair and make new cells, or does it have to do more with weakening of the face muscles? That's an excellent question. So it's a little bit different. So the skin ages due to differences, like you said, just kind of the inability to repair and make new cells as well. You also lose elasticity in the connections of your tissues. So there's not only like the epithelial cells that are not as, they're not turning over and they're not regenerating as much as they used to, but there's also the collagen in your skin that keeps it tight and bonded that's now becoming looser and more fragmented, and it just does not it doesn't have the same integrity that it did. So it's not so much the weakening of the facial muscles as the weakening of the tissue that envelops those facial muscles. And because that's weaker, it doesn't hold all of the compartments in place, and your skin just it's a combination of that's weaker and your skin is weaker. So everything kind of starts to sag. What's the benefit of doing an ENT residency and FPRS fellowship instead of doing plastic surgery straight out of med school? Facial plastics versus oral maxillofacial versus oculoplastics. Okay, that's scope. That's a great question. So basically, all of these can overlap. So I did ENT because I at first didn't know if I wanted to do general ENT. I liked sinus surgery and things like that. But then I really liked facial plastics. For a general plastics fellowship or residency, they are doing a lot of body work. They're also doing burns. They're also doing, things like wound healing, and they do general surgery for a period of time and do a lot of body work. Now, granted, I'm biased, but typically having trained in ENT and only doing that anatomy of the head and neck for 5 years versus a plastic surgeon who's doing full body anatomy and isn't really focused on just the face and neck, and also does about 3 years of training in general surgery, which means like bowel surgery. They just generally aren't as equipped to doing things like rhinoplasty and things that are a little bit more really intricately face oriented. And so sometimes they have to do an extra fellowship in that, but not always. It just sort of depends on the training you get. But can we both, a general plastic surgeon who's trained and I, overlap in doing facial procedures? Absolutely. Oral maxillofacial, that is actually, you go from dental school to OMFS residency. So as an ENT and OMFS, we did overlap a lot on facial trauma, and they would actually help us with some mandible tumor resections, and then we would reconstruct it. And oral maxillofacials are the ones that should be doing orthognathic surgery, anything that has to do with like bite alignment. And they're also doing like wisdom teeth removal, but they're not doing any like rhinoplasties, or they shouldn't be, at least be doing like rhinoplasties or blepharoplasties or kind of cosmetic facial procedures as much. I mean, maybe doing Botox and fillers, but not doing like a brow lift or things like that. They're really more kind of dentistry, trauma, bony work focused. Oculoplastics, you go to ophthalmology residency, and they are also really good at doing some cosmetic eyes and brows. They also do a lot more functional stuff, and that means like patients that have like the rolled out eyelids, like those older gentlemen I showed you, people that have orbital trauma, maybe people that have orbital tumors, or if they get like a section of their eyelid resected, oculoplastics maybe doing the reconstruction for that by taking tissues from various places. So I would say there's overlap in all the specialties, but there are certain things that only one type of specialty should be doing. Do you deal with eyelid surgery? I think I covered that. How do you tell the difference between bags under the eyes caused by allergies versus something else? Um, so allergies looks like kind of like, venous congestion, like it's purplish and stuff, but you're not going to really, allergies does not cause bags under your eyes. What causes that is fat that is herniating out. Now, you can have edema and swelling of the lower eyelids from allergies, and you can have lids that are really swollen looking, but they're not going to cause like actual compressible fat. And that's more of a feel and a experience, but you can definitely tell the difference. And plus, I mean, it's also age related. Like a 20-year-old is not going to have really big bags under their eyes unless they have some genetic predisposition. But um, it's pretty obvious when you are examining them. So swelling, purplish discoloration, things like that may be caused by allergies, but it's not going to cause those heavy bags. Those heavy bags are caused by fat. Do you work closely with dermatologists? Yes, different types. So sometimes dermatologists will, especially with, they have a lot of know about skincare, like, especially patients with like acne, or maybe they have really bad, want just that kind of glowing skin or whatnot. We get I learn a lot about skincare. We carry products at the office, but a dermatologist would be better for, certain conditions. Like I'm not dealing with rashes or acne or things like that. Additionally, there's something called a Mohs surgeon, which is dermatology trained, and they do skin cancer resections, where they take a piece and look at it under the microscope to make sure they've got all the margins, so they can take a smallest piece as possible. And I work closely with a Mohs surgeon who's a dermatologist, and I do a lot of skin cancer reconstructions. In fact, that's what I just finished doing this morning. Can you talk about the current trend in jaw exercises and their effectiveness and dangers? I don't I don't know anything about that. I don't have TikTok. So, if you're talking about facial yoga, I mean, I it's not gonna work, but it's fine to stretch out your jaw. I don't imagine there's a danger to it. I mean, you could theoretically, I guess, pop your jaw out of place and it would need to get relocated into the socket, but, there is no effectiveness. Is there a skin type that tends to get keloid scars? If so, is there a way to prevent them? Um, Typically, but not always, it is usually African Americans, but that's not to say that all African Americans get keloid scars. What a keloid is scar tissue that grows outside the bounds of a scar. So, for example, if you get cut and you get like a raised scar, but it's still in that same line, that's just called a hypertrophic scar. But a keloid is something that would grow outside of that line. So you don't typically know that you're going to get them unless it happens to you, or unless you have significant family history. The majority of time when I see patients that have them, they got their ears pierced and then all of a sudden got this big keloid growing on their ear. Um, Ways to prevent them. Well, the ways to treat them are with a combination of things like partial resections, injecting steroids, injecting something called 5-fluorouracil, which is actually a chemotherapy agent. There's laser treatments. So there are ways to treat them afterwards. Unfortunately, you don't typically keloid a lot on the face, but it could, if someone has a history of keloids, it may not be risk of doing any sort of cosmetic surgery, and or facial resurfacing. Have you done or looked into facial feminization surgery? Yes, I have done both, and I want to learn more about it. There are a variety of different things. There's, feminizing rhinoplasty. There's jaw shaves for me, even for women that have really square jaws, to kind of shave this down. There is ways called V-line surgery to kind of cut the mandible to make it a little bit more heart-shaped instead of square. There's augmentations you can do to the forehead, like decreasing the brow bone, You can actually put implants in here to disguise it. So that's a whole other topic. But yes, I do it and I am interested in it, and I'm going to try to learn more about it so I can offer it more in my practice. Um, do you work with any celebrities? Well, that is a HIPAA violation, so I cannot tell you that. How long is a typical day for you? That's a good question. Um, so it varies. Sometimes I'm in clinic, sometimes I'm in the OR, sometimes I'm doing both. Typically, I get here at about 6:30 in the morning. If we have, if I'm operating, I start at 7. So I check the patient in. I might see a post-op in the morning. I do the surgeries, and then I'll see patients in between. So I'm usually here from about 7 to 5. If it's just a clinic day, then I don't arrive till about 8:30, and I usually wear regular clothes. And then sometimes I do in-office procedures like earlobe reductions, buccal fat removal through the mouth. I do scar revisions, like little things that or things that can be done under local anesthesia that you don't need to be asleep for. So that will kind of vary on my day. Sometimes I'll just have a clinic just for procedures, which includes dermal fillers and Botox, and other, other smaller things, mole removal, stuff like that. So it really varies, which is nice. And then sometimes I do facial trauma, but not very often. I did a lot more in residency. Is there anything younger people in their 20s can do to have a better outcome as we age? That's a great question. Skincare is really the thing you should be really focusing on. I never leave my house without at least 30 SPF on. I mean, as you get older, you could think about doing neurotoxins to sort of prevent wrinkles, but skincare is the ultimate thing. So typically making sure that you're washing your face, using vitamin C serum is really good to help with brightening, wearing SPF, and moisturizing, and doing that twice a day. Um, and then maybe in your late 20s, early 30s, if you want to start thinking about or looking into neurotoxins for preventing wrinkles. But I would say the main thing you should be doing is skincare. What was your experience at Baylor? I'm from Texas, and Baylor is my first choice med school. I think it's the best med school. That's where I'm from Texas too. It was an amazing experience. They do an accelerated program. So instead of 2 years in the classroom and 2 years of doing rotations, you do 18 months in the classroom and 2.5 years of doing rotations. And I feel like that really put us a step ahead. And it's just an amazing school and amazing experience. So if you get the chance to interview there, I definitely recommend it. What are the complications? Do they end up in the ER? That's a great question. I would say there are lots of complications to any surgery that you do. And it depends on the type of surgery. As far as rhinoplasty, the main things are nosebleeds after surgery. And I have had patients that have had it. If I am able to, I will just stop them in clinic if it happens. It's very rare. It's probably like 1 in 30 patients. But I have had to meet patients in the ER, or I've had to transfer them to the hospital just because, not that they were having massive blood loss, but just we needed to go to the operating room and to cauterize it. And I think that's happened once, but it's super, super rare. The other thing with facelifts is hematoma, where you can get a blood collection under the skin. Not something you always have to go to the OR for, but it is possibility. There are lots of complications with eye procedures. That's why you really have to know the anatomy and what you're doing. But yes, that there are complications, but rarely is it. It's never. I would never say that any of them are life threatening. They're just things that you have to be aware of. But the most kind of urgent are the active bleeding. Does lips filler spread to other areas of the face? It can. If you use hyaluronic acid filler, luckily you can dissolve it with something called hyaluronidase. But it can, depending on the type that's used. How do you approach a patient with exophthalmos due to Graves' disease or any other diseases? That's an awesome question. So in ENT residency, we would do a lot of these where I would actually do it through the sinuses. So we go through the nose, and you're able to access the medial orbital wall and actually open it up and kind of debulk some of the fat. Because so Graves' disease is actually caused by the antibodies enlarging the ocular muscles. It's not necessarily, and therefore that's what causes it to bulge out. It's becoming really enlarged in a small space. So basically, that's a decompression. That's a surgery that decompresses it to allow more space. So then the fat will kind of bulge into your sinuses until the Graves' disease is treated, of course. I would say at this point, I don't really do that. I would refer them to one of my oculoplastics colleagues or someone who's doing that on a more regular basis. But that is how I was trained to do it. Do you have any recommendations for sun care brands? Not particularly. I mean, I would just say you need to at least be wearing 30 to 50 SPF. I wear a tinted moisturizer every day that has 30 to 50 SPF in it. I use It Cosmetics or like Bare Minerals, but if I'm just using sunscreen, I just use Neutrogena or whatever is available at a pharmacy. So it's not like you have to get anything fancy. It's just important to protect your skin. Those are some great questions. Is there anything else?
Thank you so much, Dr. Nagy, for presenting for our web shadowers. This was such an interesting and informative presentation, and it was an honor to have you and learn from you.
No problem.
Thank you. Everyone, make sure you check out her socials. Her Instagram is Dr. Celeste Nagy.
Yeah.
And then the link for today's Google form is posted in the chat box, and it'll be in the description of this video shortly. Please fill it out within the next 30 minutes for us to receive verification of your attendance. Again, thank you so much, Dr. Nagy.